Yes, sir. Audience is starting.
Once you've got 40, we can go ahead.
Noted, sir.
So we can start, sir. 40 and we are live.
Okay. So good evening, our beloved audience and all the students. We welcome you once again for this Master Bedside Clinics in Nephrology. We are very happy to have our course directors, Dr. P.P. Varma ji, as well as Dr. Vijay Kher for today's program. So it's an honor to have you once again to get you joined for today's fourth episode of our Master Bedside Clinics in Nephrology. And we are very happy to be associated with this program on behalf of Microlabs Limited. And I take this opportunity to welcome our course directors, and I request Dr. Vijay Kher to introduce the examiners for the day and then take it forward from here. So over to you, Dr. Vijay Kher.
Thank you, Mr. Raja. Good evening, ladies and gentlemen. Welcome to another episode of the Master Bedside Clinics in Nephrology. And the topic for today is diabetic nephropathy. Diabetic nephropathy, as all of you know, is the commonest cause of kidney disease and kidney failure worldwide, and so in India as well. Many of us, at least during our training, we used to think that diabetic nephropathy is a disease of the Western world, but then over the years, diabetes has taken over as the commonest cause of end-stage kidney disease as well as kidney disease overall in these patients. And diabetes is the mother disease of cardiovascular disease, which is very common in our patients, is the commonest cause for heart failure, is the commonest cause for retinopathy, the neuropathy, and all the other complications which occur when our patients develop diabetic nephropathy. And today, to discuss this topic, I will hand over to my co-chair, General Varma, who will introduce today's examiners and the presenter, case presenter, and we'll proceed subsequently with the discussion.
Thank you very much, Microlab, and thank you very much, Professor Kher, for this fourth edition. And as you have already introduced, it is the mother disease, the commonest bedside clinic. And most of us generally start feeling that we know everything about diabetic nephropathy because it's such a common thing. But by the end of the clinics, you always realize we knew very little about it. And I'm sure today's two examiners, one, Professor Arpita Roychowdhury, a very dynamic woman leader, nephrologist, and who has got a standing in national scenario. She is professor of nephrology and head at IPGMER, Kolkata. Not only she's heading the department, she's also joint director of ROTO, and she's executive council member of ISOT, and she has got vast experience in teaching and in publications. She has got a lot of publications to her credit, a lot of original research, and it is always a pleasure to listen to her. And she's a dynamic speaker also, and I hope we will gain a lot from her examining the student today. The other examiner today is a brilliant nephrologist, a friend of mine, Brigadier Ranjith Nair. He is a star in the field of nephrology in armed forces and a very dynamic and brilliant nephrologist, a very clear-headed and analytical, with an analytical mind. I'm sure today he is also, I mind you, he is a coordinator for all DNB programs of the National Board. At the moment, he has been a consultant nephrologist of armed forces, and he is heading and commanding a military hospital in Jaipur. I'm sure Ranjith is going to add a lot of substance to today's discussion. I hand over today's student is Dr. Rajarshi Datta. He is a DM student at IPGMER, student of Dr. Professor Arpita Roychowdhury. I hand over to them and please conduct the session. Thank you very much.
Thank you, sir, for your prolific showering of kind words. I will try to do up to your expectation. And with that, Professor Nair, will you?
Yes,
we will start now.
Yes, ma'am. Yes, ma'am. It's a pleasure to meet you online, ma'am. Last year we were together at Kolkata, and as usual, General Varma puts you on the back foot immediately by praising you so high that you have to do your best and put up your best. And I hope that we are able to live up to his description and expectations of us.
So, Rajarshi, if you
sir.
can start with the history of the patient. Dr. Nair, we will take the syndromic diagnosis differential after the history. Then we will allow him to go to physical examination. Then we will decide upon the final diagnosis. Okay,
Definitely.
Rajarshi, please start and continue.
Good evening, my respected teachers. My case is a 59-year-old hypertensive and diabetic Hindu male who is hypertensive and diabetic for the last 2 years, a driver by occupation. He presented to us with pedal swelling for the last 2 months, frothy urine for the last 2 months, and decreasing urine output for the last 7 days. Coming to history of present illness, the swelling was of insidious onset, gradually progressive in nature, pitting, started at the level of ankles and has gradually progressed to involve up to the level of the knees with no diurnal variation. It is also associated with frothy urine. Initially, the urine output was normal, but it has been gradually decreasing for the last 7 days. And at present, the patient is passing around 300 ml urine per day with an approximate intake of 2 liters per day. There is no history of any cola-colored or tea-colored urine, any dysuria, any flank pain, any pain in the limbs, any preceding history of fever, sore throat, skin rash, joint pain, cough, or hemoptysis. On further inquiry, he also says that these symptoms are associated with easy fatigability compared to before. He becomes short of breath on doing strenuous work or climbing 2 floors of stairs, which he had not noticed earlier, but has begun in these last 2 months. But there is no associated orthopnea, any paroxysmal nocturnal dyspnea, any wheezing, chest pain, weight loss, decrease in appetite, vomiting, passage of black tarry stools, altered bowel habits, pain abdomen, and yellowish discoloration of eyes or urine or back pain. And additionally, there is also no history of any nocturia, any polyuria, polydipsia, any tingling, numbness, or burning pain in the extremities, any erectile dysfunction, angina, claudication, visual disturbance, or headache. Past history, he is hypertensive for 2 years, well controlled on single antihypertensive, and diabetic for 2 years, requiring 2 oral hypoglycemic agents. No other significant illness in the past. Treatment history, he took some over-the-counter painkillers around 3 months back for left knee pain following a minor knock for a few days. But there is no documentation as to what medicine he took. There is no history of any alternative medication intake. There is no significant family history of any renal disease or cardiovascular or diabetic disease. He belongs to a lower middle class, lives in a pakka house with his wife and 2 children, and is a driver by occupation. He is non-vegetarian, eats 3 to 4 meals per day, sedentary lifestyle with no addictions or high-risk sexual behavior. To summarize, my patient is a 59-year-old hypertensive diabetic male presented with insidious onset, gradually progressive pedal swelling and frothiness of urine of 2 months duration and decreased urine output of 7 days duration with easy fatigability, but no other systemic complaints. And he has a history of intake of some over-the-counter painkillers 3 months back, which he took for a few days.
So with that, Rajarshi, as you have presented the history and summary, may I ask you that what is your syndromic diagnosis? Do you have a differential for syndromes?
Yes, madam. From the history, it appears that the patient is suffering from adult onset nephrotic syndrome. That will be my first syndromic diagnosis.
Is it pure AONS or something you want
with
to
AKI,
add?
Adult onset nephrotic syndrome with acute kidney injury.
Why you are calling it acute kidney injury?
Because the patient has been complaining of decreased urine output for the last 7 days. And according to the KDIGO definition, it fulfills the urine output criteria of less than 0.5 ml per kg per hour for 6 hours, more than 6 hours.
So for oliguria, which he has developed over the time period of 7 days, you want to add up AKI with adult onset nephrotic syndrome.
Yes.
For a diabetic patient with history of nephrotic syndrome along with AKI, what are the things that come in your mind?
The patient
differential. Yeah.
As differential, the patient might have underlying diabetic nephropathy, which will make the patient more prone to acute kidney injury due to minor insults. The patient might also have some non-diabetic kidney disease, like considering his age, he might have membranous nephropathy. He might be suffering from membranous nephropathy, and he might also be suffering from other causes of nephrotic syndrome. Considering his older age group and probable presence of anemia, he might also be suffering from MGRS or amyloidosis. And apart from that, other causes like FSGS and IgA nephropathy cannot be ruled out. These are the differentials for nephrotic syndrome.
So you want to consider a differential for the nephrotic syndrome which the person is likely having. And what for AKI? What are the AKIs that are common in diabetics? Can you fit any of those possibilities in this history?
In this history, the AKI, there are some possible causes of AKI, like pre-renal, intrinsic renal, and post-renal. In the pre-renal causes, the patient might have significant hypoalbuminemia, leading to volume depletion, which may be further aggravated by treatment with diuretics or NSAIDs.
Sorry to interrupt here. In your history, have you got any history of these events?
No, that is not available.
So let's stick to the history here.
Okay.
My question is, okay, anything beyond nephrotic syndrome?
The patient, since the patient has got history of probable NSAID intake, there might also be acute tubulointerstitial nephritis.
That was 3 months ago.
But NSAID-induced nephritis can present late.
No, that is fine. So he had an SAID intake 3 months ago, and then he noticed gradually progressive pedal swelling and frothiness of urine, etc. Isn't it?
Yes.
So other than nephrotic syndrome, you're considering an acute interstitial nephritis.
Yes, sir.
Because
anything you want to consider more? What Professor Nair was asking?
Anything more in your
differential? In a diabetic patient can have papillary necrosis. They are prone to papillary necrosis.
There is no history of hematuria.
No, there is no history of hematuria.
And you didn't give any history of flank pain, fever.
No.
Usually, pyelonephritis comes with all these symptoms.
Why can't he have chronic kidney disease?
Yes, sir. That is also a different.
Chronic kidney disease.
That is the thing Dr. Professor Nair was asking.
Papillary necrosis.
Chronic.
Definition of nephrotic syndrome is surely tenable, and yes, he may have a nephrotic illness, but a chronic kidney disease probably should be the second possible this one here, because we know that the initial stages of chronic kidney disease the patient may remain asymptomatic as the decline in GFR occurs.
Yes.
Why
could this just not be an acute on CKD?
Yes, sir. That is also
Can you tell us one pointer in your history that keeps the CKD diagnosis very much possible? You have given a pointer in the history.
Patient has got anemia. Probably.
Yes, easy fatigability is there.
So we have not examined the patient. We have not touched him as yet. To say that he has anemia is not right. Easy fatigability could be a part of the nephrotic illness. It could be a part of cardiological illness, which is not yet presented into an LVF. So you are right in keeping your options open by saying he may have a nephrotic illness, but a chronic kidney disease. You have not mentioned anything about his history of smoking and tobacco use.
He has got no addiction.
He mentioned that there was no addiction.
No addiction to alcohol or
Because
smoking or drugs.
Tobacco is very important because again, atherosclerotic vascular disease is more likely to be common in a diabetic because his certain things like historically, the overall history of duration of diabetes and hypertension seems to be low. One thing I always ask patients when they present with just 2 years of history of these symptoms is, how were they diagnosed to be diabetic? What was that precipitating event which made them get diagnosed as a diabetic? Would you know about how was he diagnosed to be diabetic? You see,
Yes.
a lot of type 2 diabetics, they remain in a honeymoon period or in a without any polyuria, polydipsia, or polyphagia. The hyperosmolar symptoms may not be there for very long. They may remain silent. So you may actually have that this individual is diabetic for 7-8 years. So was it a diabetic foot? Was it a pneumonia episode or a UTI episode, which was, and diabetes was detected incidentally? So which
Yes.
again gives you a history that possibly the diabetes existed much longer than what the patient feels or made him seek attention, medical attention.
Yes, sir. A patient had.
So currently, I would say a nephrotic illness. Yes, sorry.
So the patient had a UTI and was diagnosed with as a diabetic or during the evaluation of the urinary tract infection.
So yes. So the other thing is lower urinary tract symptoms in a 59-year-old male who has presented with history of UTI when he was diagnosed to be diabetic. You should have taken history of voiding symptoms. That is important. Does he have hesitancy, urgency, nocturnal frequency? You have also, of course, said nocturia, but nocturia deals more with volume rather than frequency. So when we use terms, we should be clear about what we mean. So nocturnal frequency, then stream, post-void hesitancy, dribbling. These are important things. So you have summarized and presented it very well till now, but these are a few things which I felt could have been added. In my take on it, I would have put CKD higher and a nephrotic illness lower down because of his history and the fact that he presented with UTI for the first time and then was diagnosed to be diabetic. I would assume that the diabetes existed for a much longer duration of time than what the patient has told us, or rather when he came to actually know.
I'm sorry, I'm inclined to agree with Ranjith. Why have we put nephrotic syndrome? Because simply he presents with edema feet. We can't put a diagnosis of nephrotic syndrome.
Yes.
We don't have any data. That is your first diagnosis in exam.
Yes.
On what basis you are saying nephrotic syndrome? When you are saying nephrotic syndrome, there is a distinct definition of nephrotic syndrome.
Yes.
Maybe after the investigations were there, possibly you could have said it is there. But possible diagnosis at this stage, to my mind, will be maybe acute or chronic CKD.
Acute on CKD should be a first differential considering his age, the associated comorbidities of diabetes, and the fact that he presented with a UTI and was diagnosed to be diabetic. Because if you see, he fits into the diagnostic criteria of diabetic nephropathy. Progressively increasing pedal edema, frothuria, and decline in GFR, which could also be represented by your declining urine output, which of course could be an AKI. That is one thing which is very tenable.
Yes.
You could, how should I say, defend your diagnosis. Let us say what is more common. How many patients, let's say if we take 100 diabetics at 59 years of age who present with this illness, how many of them are likely to have membranous GN or FSGS?
So
much lesser than
1/3 patients will have plain diabetic around 36% patients, around 1/3 patients will have plain.
No, that is, we are talking about the biopsy proven diagnosis of diabetic nephropathy in patients with diabetes and CKD.
Yes.
You see, that is almost 40% patients will have pure diabetic nephropathy. Another 40% will have an overlap of diabetic plus non-diabetic kidney disease, in which we have AIN, chronic pyelonephritis, IgA nephropathy, MG, and so on and so forth. And another 20% will have, or 30% will have completely isolated non-diabetic kidney disease. So that, of course, I mean, that is a theory part which we discuss after we have confirmed our syndromic diagnosis. In my opinion, I would still like to keep a CKD with an acute on CKD higher up, a nephrotic illness, because if you see what are the diagnostic criteria for nephrotic syndrome? There has to be
Patient
proteinuria,
has to have nephrotic range proteinuria and hyperalbuminemia.
hypoalbuminemia, hypercholesterolemia, and then
edema.
edema.
Yes.
Yeah.
That we may confirm.
So edema could be because of multiple reasons.
Yes, sir.
Dr. Nair, we may take up the physical examination and then settle
yes,
on whether it is an AONS or CKD.
Yes.
The AKI we are almost sure of, and this rapidly falling EGFR, which causes 300 ml urine output within 7 days,
yes,
without other insult before,
this we have
definitely keeps an AKI, whether it is AONS or CKD. Yeah, acute illness is there. So if you go to physical examination, Rajarshi.
Yes. Coming to general examination, the patient is alert, conscious and cooperative. Decubitus of choice. AC is normal. Pallor is present. Edema is present.
Rajarshi, just a minute. When you say AC is normal, I expect you mean to say there is no periorbital puffiness?
Yes, sir. There is no periorbital puffiness.
That goes a little bit against what your history says, that he's been having a 300 ml per day urine output with a 2-liter intake, which means in the last 7 days he should have gained at least 1.5 into 7 is almost 10 to 15 liters of weight.
So,
did you examine the patient on the first day, or the patient had received any treatment? That becomes important.
The patient had got admitted, and I had examined him after 2 to 3 days. After 3 days.
Okay.
After admission.
Okay.
There is bipedal pitting edema is present up to the level of the knees, and there is also presence of scrotal edema. There is no cyanosis, jaundice, clubbing, or lymphadenopathy. The neck veins are not engorged. There is no abnormality noted in the skin, hair, or nails. A body mass index of 26 kg per meter square. His blood pressure is 130 by 80 millimeter mercury in sitting position in both the arms. No postural hypotension is present. Pulse rate is 88 per minute regular. No special character. No radioradial or radiofemoral delay. All peripheral pulses are equally palpable. Respiration is 12 per minute regular. Patient is afebrile. Coming to systemic examination.
Can we just, sorry, Rajarshi, can we stay here, please? Can we go back to general examination? Just go back to the general examination part, please. So,
yes,
according to your general examination, what is the hydration or fluid state of this individual? Do you think what is his intravascular volume looking like to you?
The patient does not appear to be volume overloaded.
Yeah, because
the patient does not have. Yes.
So the blood pressure is good.
Blood pressure is normal, and the jugular venous pressure is, the jugular neck veins are not engorged.
So you are not expecting a central volume overload. So whatever edema you are looking at is likely to be.
So important part here, which you have probably not told us, is the treatment history in the last 3 days since when you have.
Yes.
Yes, Manu, I acknowledge that volume overload includes interstitial edema too. Yes, we're talking about the intravascular volume here. So the treatment history becomes very important. What ma'am has already highlighted, it looks likely that your patient has been treated with some medication. It should have been a part of your history, that he has been receiving medications in the last 3-4 days since his admission, which has increased his urine output, or he has been asked to reduce salt and his fluid intake, with which he has had some kind of weight loss. Something we have to mention here. That puts things back in perspective.
Yeah, hospital course you add up.
Okay. The patient had.
He's already been dialyzed. Okay, fine.
So that's why I kept it later. I kept the hospital course later.
Okay. So, fine. I'm sorry. Then please carry on. Yeah.
So, coming to systemic examination, the patient does not have any CVS examination. The apex beat is in the left fifth intercostal space medial to the mid-clavicular line. There are no murmurs, and there is no gallop rhythm or any murmurs or any rub heard, pericardial rub heard.
What would be the important part in a cardiovascular examination if this person was seen by you in the casualty on the first day of arrival?
I have to check whether there is any evidence of any pericardial effusion, whether the patient is in heart failure, and If the patient is a chronic kidney disease patient, if he has got any pericardial friction rub, that is an indication to start dialysis.
Okay.
Now,
Fine. So pericardial rub would be extremely important. 3-4 comments have already been made. Would you have any more data on the kind of antihypertensives that he was? Was he receiving ACE inhibitors?
So that the patient could not
mention. Dr. Manu Dogra wants to know the markers of atherosclerosis and malnutrition in general examination. We've already mentioned his BMI.
Patient,
anything else in the general examination which is important?
So in the nails were also
already mentioned the skin, hair, nails, etc. No abnormality. The only thing you could have also mentioned was things like xanthomata and xanthelasma.
Xanthelasma, yes.
Rajarshi, what are the skin changes that you expect in CKD patients that you like to look for?
In the nails, the patient might have half and half nail or Lindsay's nail, and that can give an indication of presence of chronic kidney disease.
And in the skin, particularly in diabetic CKD?
Yes, what skin changes do you expect in a diabetic, especially in the lower limbs?
Any acquired perforating dermatosis if it's present, any rash is present with dry skin.
Okay. What else? What are the secondary changes that occur in the skin which
if there are any pruritus, marks of pruritus, if there are any,
of course,
if there are any ulcers,
of CKD.
If there are any ulcers and the location of the ulcers.
You look for pressure source, but much before pressure source, anything which can tell you that
absence of sweating, absence of hair, shiny skin, absence of hair,
yes,
absence
shiny
of sweating.
Absence of hair, cracked nails, dry cracked nails. Yeah, these are important. They would give you a clear history that the duration of diabetes is much longer than what the patient is aware of. Yes, loss of hair and sweat. Yes, so all of us have discussed this already. Yes, Dr. Datta, please carry on. So cardiovascular examination, yes, an LVS3, an LVS3
is not there.
Presence of a rub. Yes, a presence of a rub. These are important things that we would like to hear when the patient comes to us. Why is that rub so important?
Sir, that is a
why is looking for a pericardial rub in a patient? How does it alter our management?
If it's a uremic pericarditis, that is an indication of renal dialysis, renal replacement therapy.
Not only dialysis, it's a heparin-free
dialysis.
Dialysis. What about what's so special about heparin-free? You should make sure that it's right there in block letters. Do not give heparin to this patient. And how energetic will your dialysis be?
So the first dialysis,
in such a patient, you would like to.
I will not like to dialyze very aggressively. I would like to. The first session would ideally be for 2 hours, and the urea reduction ratio I would target 40% instead of 75%.
We would like to give short, frequent hemodialysis, which would literally mean short, progressively increasing daily dialysis.
Yes.
Which is heparin-free. Yes. So these are specific practical important. Colonel Manu Dogra wishes to know if there was an LVS4 at all. He is hypertensive. Was there a fourth heart sound?
No, there was not.
With a heart rate of 88, no, there wasn't. Okay, maybe the diastolic dysfunction or the LVH is not very much. The respiratory system?
The upper respiratory tract and trachea is in central in position. The nasal cavity normal. No vocal fremitus.
So there was nothing abnormal that you found?
There was nothing abnormal. There was no evidence of any bilateral
abnormality in the
nasal crepitations. There was no presence of any.
You didn't find any pleural effusion. The patient is.
It was normal.
History was like anasarca.
Yes.
Okay.
I could not
find. Okay, fine. Clinical examination was unremarkable. Fine.
Coming to abdominal examination, the flanks are full. Fluid thrill and shifting dullness are present. There is no organomegaly, no renal angle or abdominal tenderness. The bladder is not palpable. An auscultation, no brew is heard.
Rajarshi, once again, I take you back. There is no pleural effusion, but ascites. In a diabetic patient, when there is singularly ascites and no pleural effusion, do you want to bring something else in? Did it bring something else in your mind too?
Presence of any constrictive pericarditis, any presence of any chronic liver disease,
presence of a NASH related liver CLD, NASH CLD is a possibility, because in diabetic patients, we are now often finding involvement of liver and kidney both. So if it is isolated ascites, it should alarm you that whether you are dealing with a liver disease as well.
So a very simple question which we ask everyone is, though historically you mentioned that whatever history you mentioned, there has been a definite vitiation of that presentation with the therapy that we have given to him. But if the patient had predominantly ascites and dependent edema disproportionate to facial puffiness, where does this take our diagnosis towards?
I must at this point of time sort of caution both the examiners that you have 45 minutes. Time is important. So you have a diabetic nephropathy, which you have to, you're not discussing chronic kidney disease, not only differential diagnosis. So this is a diagnosis already given in this patient. So my suggestion would be, you have to discuss diabetic nephropathy, and you have only 45 minutes left. Fine, 7:45. So keep time scale on that.
Yes, we'll leave it at that, sir. Okay. Right, sir. Point taken, sir. Yes, Rajarshi, please go on.
Yes, sir. The central nervous system examination was essentially normal. There was no abnormality in the joint position or vibration sense, and all the reflexes were present. And on fundoscopy, there was no evidence of any diabetic or hypertensive retinopathy. In dipstick examination, there was 3+ protein and no blood. In urine microscopic examination, there were 4 to 5 WBCs per high power field, few renal tubular epithelial cells, no RBCs or casts. Urine culture did not reveal, urine culture and sensitivity revealed no growth.
Okay, fine.
So,
how have we decided that proteinuria is nephrotic range? Because it's 3+ on dipstick.
So it has to be confirmed by 24-hour urine protein, but considering the
proteinuria, yeah. So when you say 1+, 2+, 3+, what does 3+ equate to literally?
3+ means there is around more than 500 milligram per dl concentration of protein in the urine, and 4+ means more than 1000 milligram per dl.
Yes. So please remember, it's per deciliter. It's not per liter.
Per dl. Yes, sir, per dl, per deciliter. Yes, per deciliter. Yes. Milligram per deciliter.
Please go on.
So in the hospital course, the patient received some IV and oral medications, following which the edema subsided and the urine output increased. Patient received 4 sessions of hemodialysis by right internal jugular catheter, and he also underwent renal biopsy. And at present, the edema has subsided. Compared to before, urine output is 800 ml per day, and he is off hemodialysis for the last 3 days.
Okay.
So after examination, I would still like to keep the same differentials. I still cannot rule out chronic kidney disease. I still cannot rule out the nephrotic syndrome might also be present, and there might also be an acute on chronic kidney disease. And the cause of the chronic kidney disease is probably diabetic nephropathy.
So what all in your initial
Madam, I cannot hear you.
Differential from
Sorry.
No problem. What all from your history following your examination and urinary, what all can you exclude with confidence? Is there acute interstitial nephritis?
So acute interstitial nephritis might be present. I cannot rule it out. It still might be present.
With the current evidence of what is there
3+ proteinuria is little unlikely in interstitial nephritis.
With 4 to 5 WBCs. With 4 to 5 WBCs.
But madam, in this
RBCs.
induced nephrotic syndrome, it is a bit different from other usual causes of nephrotic syndrome. So we might get rarely. So I cannot completely exclude it.
Your history says that he took NSAIDs 3 months ago.
Yes, sir, 3 months ago.
So that is already over.
But sir, it can present even after 6 months after intake of NSAIDs. Even after 6 months, it can present with nephrotic syndrome. It can also present with nephrotic syndrome.
Okay. So, NSAIDs causing nephrotic syndrome is a different situation from NSAIDs causing interstitial nephritis, allergic interstitial nephritis. They can cause glomerular disease, like Dr. Manu Dogra is pointing out. NSAIDs can induce minimal change disease. That's a nephrotic syndrome. That's different. Yeah. Fine. So, in the absence of diabetic retinopathy, how does that take your diagnosis away from a possibility of diabetic nephropathy?
In type 2 diabetes, the presence of retinopathy is not essential for the diagnosis of nephropathy. In type 1, in 90% of the cases, retinopathy is present.
So
But in type 2, it is only around
the
60%.
Yes,
Sorry, sir, I cannot hear
both
you.
ways. That is, in 60% of unstable. Sorry, I can't. Can you hear me now?
Yes, sir. Yes.
Yeah. So there's about 60% concordance of diabetic nephropathy and diabetic retinopathy. What is the other microvascular component, microvasculopathy that we have looked for in this patient and not found on
Neuropathy.
clinical
We
examination?
not find any neuropathy.
Neuropathy. That is also slightly unusual because a diabetic nephropathy is a microvascular disease and it usually is associated with one of these two, but there's only 60% concordance. So the absence of it does not rule out the possibility of diabetic nephropathy.
Rajarshi, in your differential of nephrotic syndrome, you have kept lowered down FSGS and IgA. I think with absence of any
RBC,
active,
I will rule out
yeah,
IgA nephropathy.
IgA nephropathy, at least you can comfortably rule out. And we may proceed to the investigations. Let's proceed to investigations.
The patient had 24-hour urine protein of 11.1 grams. Urine routine, the serum albumin was 1.4 and globulin was 4. The urea was 97 and creatinine, this was at presentation. The creatinine was 9.69 milligrams.
So one question, Rajarshi, when do you consider biopsy in a diabetic nephropathy patient? You are thinking that he might be diabetic CKD or diabetic nephropathy, still you want to consider a biopsy.
If the patient has rapid progression of the renal dysfunction or rapid increase in the proteinuria, then that is an indication of renal biopsy. If a patient has got RBC casts in the urine or any suggestion of any systemic disease, then the patient deserves a renal biopsy. In cases of, if a patient has got nephrotic range protein, if the patient has got proteinuria before the onset, before the official diagnosis of diabetes, means he was having proteinuria from before, and then that is also an indication of biopsy. In type 1 diabetes, if the patient does not have any retinopathy, then the patient has to have a biopsy.
Please remember,
relative indication is very high proteinuria.
Very high.
Usually, 5-7 gram we expect in diabetic nephropathy up till that. If the proteinuria is even more, we may think that it's not that absolutely no diabetic nephropathy patient can have more than 10 gram proteinuria. But when the proteinuria is too high, then also it's a soft indication of biopsy. Here,
remember, we should
biopsy is justified because of rapid fall of eGFR in the patient, very high proteinuria with a relative short duration of diabetes also. In type 2 diabetes, you can have at the beginning also presentation, you can have proteinuria. But if such a high amount of protein is excreted with a 2 years duration, you need to consider other causes of proteinuric renal disease as well.
See, by definition, this patient of yours has nephrotic syndrome.
Yes, sir.
Diabetics who present with nephrotic range proteinuria do not have nephrotic syndrome. Let us be clear about this. Let's differentiate nephrotic range proteinuria from nephrotic syndrome. So if a diabetic presents with nephrotic syndrome, you have to biopsy him or her.
Yes.
That is very clear. And like ma'am has already said, if the proteinuria is extremely heavy, nothing prevents a diabetic from having multiple myeloma or amyloid. So if you have nephrotic syndrome, he's got hypoalbuminemia. There is no reason why he should have hypoalbuminemia with such short duration of illness. So anything which takes the patient's clinical findings away from the routine diabetic nephropathy that you usually see, where there is a gradual sequential progression of increase in proteinuria, decline in blood pressure control, and decline in GFR, you may get away with an ultrasound which shows normal size kidneys. You may do away with the biopsy, and there is diabetic retinopathy associated. But here you are having one outlier after another. Here is a patient who's got 11 grams of proteinuria. Now, whether this 11 grams was in 300 ml of urine or was it in 600 ml of urine, that makes it even worse. The total volume of urine becomes extremely important here. So that is number one. Number two is he has hypoalbuminemia and hypercholesterolemia. Yes.
Yeah, that completes the definition of nephrotic syndrome. with hypoalbuminemia.
But now he fits into nephrotic syndrome with AKI.
Yeah.
Hypercholesterolemia, and he has AKI because currently his decline in GFR is only possibly of 7 days duration or an acute on CKD. We have to consider that.
And it was a dialysis requiring AKI. So what does the biopsy tell us if we rapidly move into the disease proper?
Yeah, ma'am, can we just go back to the previous slide? One more set of investigations were left.
Yeah.
Yes. So this is what I was. Yes.
Yeah. We should
also, though there is no evidence of viral markers are definitely to be looked at. The HbA1c is not really very high. The important part is evidence of vasculitis markers,
and
the evidence of myeloma. All those are not there. Yeah. So.
And the kidney size is normal.
What does this PLA2R anti-PLA2R? Yeah. What does this PLA2R antibody take you towards?
Membranous nephropathy.
The possibility, primary
membranous nephropathy.
You could have a secondary membranous.
Yes.
In history, he had told the
normal size
pointers.
kidneys with it.
Dr. Nair, he has given very important component of history in which he was excluding the bowel symptoms and the chest symptoms, which may be associated with RPGN-like causes or malignant issues.
Yes. But what is important is that these should be included, highlighting here that these should be included in the evaluation of a patient who presents with symptoms which are not associating with diabetic nephropathy. Yes, please carry on.
Coming to the renal biopsy in the light microscopy, the hematoxylin and eosin stain sections included renal cortex and medulla. In the glomerular compartment, 21 glomes were present, 5 globally sclerosed. The viable glomeruli were of normal cellularity, diffuse mesangial matrix expansion with occasional Kiman-style Wilson nodules identified. Glomerular basement membrane was no spikes or double contours were seen. No endocap hypercellularity or fibrinoid necrosis or crescent
so, seen. With this description of glomerulus, which classification, which stage of diabetic nephropathy? Is it diabetic nephropathy?
Yes, ma'am, it's diabetic nephropathy.
So which class?
Class 3. Class 3 RPS.
Class 3 has 2 sections.
No, class
2A, 2B.
Class 2 has 2 sections.
Yeah.
3 requires the global.
3 is with KW, it is 3.
KW and less than 50% global glomerular sclerosis.
Yes.
This falls into class 3 diabetic nephropathy.
Class 3. What is the importance of this tubulointerstitium?
Yes.
Even the tubulointerstitium is involved in diabetic nephropathy. It is included in the staging. There are 2 components, IFTA and interstitial inflammation. If IFTA is graded 3 scores, 0, 1, 2, 3, that is 0%, 0 to 25%, 25 to 50, and more than 50%. And interstitial inflammation has got 2 scores, 1 and 2. If it is present only in the IFTA, means the fibrotic areas, or if it is present outside the IFTA, in the normal interstitium.
Yes. And the vascular changes, what do you expect in diabetes?
There's arteriolar hyalinosis and arteriosclerosis.
That you are finding here.
Yes.
So, will you tell us a little about the classification? Stage 1 to stage 4?
Yes, ma'am. In stage 1, there is only glomerular basement membrane thickening, more than 395 in females and more than 430 in nanometer, more than 395 nanometer in females.
Do you expect to see it in light microscopy?
In electron microscope, it's in electron microscopy diagnosis, 430 nanometer in males and above the age of 9 years. That is class 1, and there should not be any changes of class 2, 3, or 4. This is class 1. Class 2 is subdivided into 2A and 2B. 2A is mild mesangial expansion, that is less than 25% of the mesangium, and 2B is severe mesangial expansion, that is more than 25% of the mesangium. Stage 3 is presence of Kiman-style Wilson nodule, and there should be no class 4 lesion, and class 4 is more than 50% glomerular sclerosis. global glomerulosclerosis.
Do you have any differential for this nodular glomerulosclerosis?
Yes, madam. For nodular glomerulosclerosis, there are some differentials. One is presence we can get nodular glomerulosclerosis in MPGN. In MPGN, we can get it in immunotactoid glomerulopathy. We can get it in collagen type 3 nephropathy, fibronectin nephropathy. We might get it in cyanotic.
Is there some way to classify? No, this is just a list. Is there some way to classify?
Yes, if it is past
positive, past negative,
with the help of light microscopy, IF, IHC, we have to see if it is past positive.
So first
usually
is light
diabetic is
microscopy.
past positive in light microscopy. Diabetic is past positive. Amyloidosis is weakly past positive.
What isn't past positive?
Amyloidosis is weakly past positive or past negative. And
yes.
And MPGN will be past positive, but in MPGN, I will get lobular accentuation and double contour of the GBM, and in IF I will get complement or immune complex deposition. So that is how I will differentiate from MPGN.
What will you get? What will you get in the IF in a diabetic
in amyloidosis? In amyloidosis. In diabetic nephropathy, I will get linear IgG staining in the GBM and in the tubular basement membrane. They might be polyclonal IgG1 linear staining.
What else?
And
the IF
you can get fibrin.
I can get other. I can get fibrin caps. I can get capsular drop.
Yeah. If you use those antibodies, then in IF you will find fibrin and albumin.
Yes. Then of course immunotactoid and fibrillary deposits, you will need to do an EM.
EM, yes.
So every level of kidney biopsy, it's always best to classify. It's easier to remember that.
Yes. And in EM we can differentiate on the basis of the size of the fibrils. In 8 to 12 it will be amyloidosis. 12 to 20 will be fibrillary, and 30 to 50 will be immunotactoid. And
not just the size, but also the distribution of the fibrils.
Yes, it will be non-branching, randomly oriented in cases of amyloidosis and fibrillary, and it will be parallel array in immunotactoid.
Parallel.
And
in very good.
And in fibrillary and the DNA JB9 will be immune staining will be positive.
Good, good.
Wonderful.
There is also idiopathic noise.
So with this, go to the IF, go to the IF.
In immunofluorescence, there are 8 glomeruli present. IgG1 shows 1+ linear positivity on the glomerular and tubular basement membrane. No light chain restriction is seen, and all the rest are negative.
Okay.
So only one point, Rajarshi. If you do biopsy in diabetics, you find tubulointerstitial inflammation so commonly that it is very difficult to say that whether this inflammation is really due to NSAIDs or it is the part of the diabetic nephropathy itself. It is quite common in diabetic nephropathy too to have the tubulointerstitial inflammation. The interstitium is mildly edematous, that the tubules are not very back to back, if you say us. That is a little hint that there might be a coexistent AIN, because in true diabetic nephropathy, we do not find any interstitial edema.
But ma'am, in favor of his this one for AIN, we also do not have any other historical or examination or investigatory finding as to why did this man go into acute on CKD now?
Yes, that is one important pointer. That is only identifiable pointer for AKI.
Yes. Yeah. Because he seems to have had an acute on CKD.
Yeah.
And we don't have any other what would be the condition that we would think of normally, Rajarshi, in a diabetic who comes with a sudden decline in renal function? Common ones that if 100 patients present like him, what would be the predominant cause of an acute decline in GFR and death?
Sir, it can be due to papillary necrosis. It can be due to
don't tell papillary necrosis.
How many
can get an acute pyelonephritis.
You can get due to Due to NSAIDs,
Infections.
Infections are the commonest cause of decline of GFR in a diabetic.
Yes.
And another is drugs.
Drugs.
Sometimes they are newly introduced on ACE inhibitor or ARB.
Yes, which is why we asked, was he given ACE inhibitors in the recent past? Maybe some energetic young physician decided, oh, he's got diabetes and he's got kidney dysfunction, proteinuria, let me give him ACE inhibitors. That is number one. Of course, interstitial nephritis related to drugs can at any time occur. So infections, drugs, and in drugs, do not forget alternative medicines. That also can happen. He could have gone to some kind of a alternative practitioner of medicine.
Yeah. He mentioned that alternative medicine is not there.
Not there.
Yeah.
So this, and then of course, a silent MI or silent cardiac dysfunction, which causes hypotension. These are other issues. But of course, infections remain the commonest cause of acute decline of GFR in diabetics. Okay.
So what is your take now after doing the biopsy? Biopsy is the gold standard for diagnosis, na? So do you consider any non-diabetic kidney disease, or you are sure that this is a diabetic nephropathy alone?
This is diabetic nephropathy.
Yes.
So does it fit into the routine understanding of how diabetes causes nephropathy and renal dysfunction? What was called the Mogensen's calendar, which Mogensen made for type 1 diabetics?
No, sir, it does not fit. It is applicable only in type 1. In type 2, it does not follow that pattern. In type 1, usually we see onset of proteinuria after around 10 years. 11 to 23 years. Microalbuminuria 13 to 25 years. And renal dysfunction 20 to 30 years. That was the original timetable description, but then later.
So why does it get shortened in type 2 diabetes?
Because in the type 2 diabetes, the exact the point of diagnosis of diabetes is uncertain. The patient might have been suffering from diabetes for a long time when he first presented to the practitioner.
Yes.
What are the most important factors, Rajarshi, in pathogenesis of diabetic nephropathy? Because soon we will move to management. So you need to know the important pathogenic issues that you like to address. Suppose the infection is over, this patient lands in a creatinine of 1.2 with a proteinuria of 1.2 gram. Now, how you are going to deal with his diabetic nephropathy? He is still diabetic nephropathy?
Yes, ma'am.
Yes. So what are the things that you will concentrate upon while you will plan his management?
The management of diabetic nephropathy has certain components. First component, the non-pharmacological measures. The things which have shown definite role is physical activity, weight loss, and smoking cessation. These three are included in the lifestyle measures. Then is cardiovascular risk protection. All patients of diabetic kidney disease, they deserve to be, they have to be started on statins. And among the statins, the atorvastatin is preferred if there is renal dysfunction. Then there is glycemic control and blood pressure control and RAS inhibition. In glycemic control, in this
that
patient,
is the pathogenesis I was asking.
Yes, ma'am.
Why you are interested in control of blood pressure to a target? What are the trial evidences that take you to the decision that control of blood pressure is likely to benefit the patients in near future? And at the time of choice of antihypertensive, why do you go for so much for RAS inhibition?
Yes, in the trial evidence, they have shown benefit of the ACE inhibitors. The trials which have shown this include separately type 1 and type 2. In type 1, there was the captopril trial. In type 2, there was the irbesartan trials, the IRMA2, IDNT trial, and the losartan in the renal trial. And apart from this, there was a roadmap trial which showed that olmesartan could prevent the onset of microalbuminuria if given before the onset of microalbuminuria. Is a possible one in preventing the onset of microalbuminuria.
So what target of blood pressure would you be asking the patient to follow?
I would target less than 130 by 80 in this patient.
So Rajarshi, what I would like to tell you, whenever you are going through trials for gathering evidence, look into little deep in the trial. All these trials you have mentioned, they have shown that the first thing they have shown that control of blood pressure, how they have prolonged the GFR protection down
Advanced
the line.
trial.
So
Advanced.
yes. So that is the thing I was asking, that even a 5 millimeter blood pressure reduction, 10 millimeter protected GFR for long time.
You have not mentioned UKPDS 33.
UKPDS also.
So
UKPDS was very important for a few reasons.
For both the diabetic control as well as the blood pressure control.
The most important part of UKPDS was it showed that no matter what you use to control the blood pressure, as long as you got a decline in systolic and diastolic blood pressure, you prevented progression of diabetic kidney disease.
Yes.
So it is not just ACE inhibition. Of course, IRMA and IDNT and other trials showed you that ACE inhibition helps by reducing proteinuria and by reducing blood pressure. But there is a clear evidence that reducing blood pressure alone, irrespective of what drug you use, does benefit patients. However, the benefit of proteinuria reduction resides primarily with ACE inhibitors, ACE receptor blockers, and certain set of calcium channel blockers. And of course, other drugs which are there, like aldactone and so on.
And you will always find in diabetic nephropathy, you are hardly able to control blood pressure with 1 or 2 drugs. The average requirement of blood pressure medications go to 3.5, 3.6. If you look at, so you have to include other classes too, if you are to touch the blood pressure target. So first thing important is achieving a blood pressure reduction. Even if there are some patients who have significant atherosclerotic stenosis of the renal arteries, where you are prohibited from using the RAS inhibitors because they will cause hypokalemia or rise of creatinine. If you can address the blood pressure, then also you are going to help your patient quite a lot. So that is a very, very important thing that you have to achieve the pathogenetic factors. If you think in your mind in the background and then address the management, probably first player we have the metabolic things that you are to keep in good control. That is why you have seen in UKPDS and DCCT EDIC 2 types of diabetic patients and a very good control of blood pressure, even retained in metabolic control of blood sugar, retained in the metabolic memory, even reflected in better preservation of eGFR. So hyperglycemia, when you pick up the patient early, hyperglycemia is a very, very important thing that needs to be addressed. Sometimes in advanced diabetic nephropathy, the hypertension control becomes the more important thing. But when you get the patient early, hyperglycemia being the major player in activating several pathways in the kidney, which is actually going to cause the ultimate damage, the podocyte damage, the interstitial damage, the vascular damage, all the cytokine related pathways, they can be better controlled if you can control hyperglycemia, if you can get down with ages, and ultimately, so these 2 trials come in again for the good glycemic control as well. So
yes, ma'am. The pathways were.
Why can't we combine ACE inhibitors, ACE receptor blockers? What is the evidence which tells us whether we can use it or not use it? What is the evidence currently available?
There is a risk of hyperkalemia. The evidence is the on target and the VA nephron D.
And not just hyperkalemia, it also causes like worsening of acute kidney injury.
Worsening of AKI. And in the
precipitous drop in GFR.
And precipitous blood pressure drop. 3 important points, Rajarshi.
Yes.
Not only hyperkalemia, acute
kidney injury,
and hypotension. Increased syncopes. Postural hypertension is more, particularly in the elderly. VA nephron D had significant. VA nephron D is mainly in elderlies. Yes.
Yes. So from blood pressure control, we move on to now glycemic control.
Glycemic control. I would like to keep the HbA1c of this patient around 7%. It actually depends on many factors. It has to be individualized. Okay. If the patient has got long-standing duration of diabetes, he has got many comorbidities, he has high risk of hypoglycemia and very less probability of attention given in case of hypoglycemia, then I would like to be more liberal and keep it between 7 to 8. But if patient has got relatively short duration of diabetes, good means low risk of hypoglycemia, then I would like to keep it around 7%. And in case of very younger patients, I would like to try 6.5 also, but mainly around 7%, HbA1c around 7%.
Okay.
What are the drugs that we will have to give up as the GFR worsens? Rather, let me put it this way: when a diabetic comes to you initially, what are the drugs that you would like to give as first-line therapy for any diabetic with or without kidney disease? And as GFR worsens, what are the drugs that you would be careful with?
As GFR worsens, I would we have to be careful with metformin. If the GFR is less than 45, then the metformin dose maximum dose of metformin given can be 1 gram. And if it is less than 30, then metformin has to be taken off. The sulfonylureas, they have got very long half-life, so they're not preferred in kidney disease. If we have to choose sulfonylurea, I would choose glipizide. I would not choose glyburide or any other sulfonylurea. I can give glyclazide, but it is not recommended below eGFR of 40. Then coming to DPP4 inhibitors, linagliptin can be given in any stage of renal impairment, but it has got very modest anti-hyperglycemic efficacy of only 0.5 to 0.8%. The other DPP4 inhibitors, they can be given, but the dose has to be adjusted. The GLP-1 agonists, they have some cardiovascular benefit. The liraglutide and semaglutide can be given in renal impairment. Liraglutide, semaglutide, and dulaglutide can be given without any dose adjustment. Then coming to SGLT2 inhibitors, the dapagliflozin can be given, can be initiated if the eGFR is more than 25, and canagliflozin can be initiated if the eGFR is more than 30. I would, even if the patient reaches dialysis stage, I would like to continue these medications to give the cardiovascular benefit, even though it might not give any anti-hyperglycemic benefit. And DPP4.
So which of these drugs are more likely to cause hypoglycemia in our CKD patients?
The sulfonylureas can cause hypoglycemia, and the glinides, the rapaglinide, netaglinide, they can cause hypoglycemia, and insulin.
The insulins, of course. So according to ADA, which is the first line of therapy for first 2-3 drugs which are to be used in diabetics today?
SGLT2 inhibitors, GLP-1, metformin.
Metformin remains a global choice. The only thing is, all of us have personal preferences. One thing we have to be very careful about, there are increasing evidences of patients with absolutely normal renal function presenting with unexplained, uncontrollable, severe metabolic acidosis when you combine SGLT2 inhibitor with metformin, and which requires dialysis. The creatinine doesn't go up, the urine output doesn't fall, the patient doesn't have infection, but they have a persistent acidosis lasting 48 to 72 hours after stopping the drug. So when you combine SGLT2 inhibitors with metformin, you have to be extremely careful. So once you've said already that the HbA1c target should be 7%, definitely not below, because the more tight the blood sugar control in this, the greater chances of precipitating hypoglycemia. We have discussed the various drugs that are available. So the new kid on the block is SGLT2 inhibitors.
Professor Nair,
yes,
one point I want to get clear. SGLT2I has come beyond the hypoglycemic effect in CKD patients. So
Yes.
they have been also used in non-diabetic CKD patients. So what do you think the basis of the pleiotropic effect of SGLT2I? What are the pleiotropic effects that SGLT2I does have, and what impact does it have in the current treatment of diabetic nephropathy? Rajarshi, am I audible?
Yes, ma'am.
Yeah.
So, madam, this SGLT2I inhibitors, they have both cardioprotective as well as renoprotective effects. There are various factors which lead to this. Firstly, by restoring the tubular glomerular feedback, they reduce the afferent arteriolar vasodilation and reduce the tubular and reduce the renal intrarenal, the glomerular hypertension and the hyperfiltration. It
So
causes
you don't want to transmit the systemic hypertension to the glomerulus. So that way the afferent arteriolar vasodilatation protects the glomeruli from development of glomerular hypertension and consequent hyperfiltration injury. Okay, number one. Number two,
it blocks the absorption of sodium and causes natriuresis.
Rajarshi, what you have to tell ma'am, what you have to tell ma'am is how is an SGLT2 inhibitor better than an ACE inhibitor? That's basically the difference, the essential difference between what SGLT2 inhibitors do over and above ACE inhibition, or how do they accentuate the effect of ACE inhibition?
SGLT2 inhibitors over and above the ACE inhibitors, they also have a role in decreasing the inflammation. It acts on the inflammatory path, decreases the inflammation, decreases
no,
the.
I'm talking just of. No. I'm just talking of the intraglomerular hemodynamics. What happens when you block the RAS pathway with ACE inhibitors or ACE receptor blockers over time? When you said that glomerular feedback, yes, they act on the yes, then
afferent arterial and SGLT2I, they act on the afferent arterial.
Efferent. So the ACE inhibitors act on the efferent, cause efferent arterial vasodilatation, reduce intraglomerular hypertension. But what happens downstream?
Downstream, the SGLT2Is, they reduce the energy and the oxygen consumption by decreasing the absorption of sodium. They cause an natriuresis. And with this natriuresis,
yes. So what they do is the distal tubular flow is maintained. They ultimately maintain distal tubular natriuresis and volume. When there is natriuresis, along with it, volume goes out.
Volume goes down. Weight loss.
Glomerular, yeah. No. What you have to understand here is the tubulo-glomerular feedback becomes a negative one when you give only ACE inhibition or ARB, and overall the effect of ACE inhibition and ARB tends to wane over time. However, when you give SGLT2 inhibitors, it prevents this feedback from becoming negative, and both of them continue to act. So you have continued benefit of ACE inhibition along with persistent, rather maintained distal volume, distal tubular flow. Yeah. Which is why SGLT2 inhibitors help so much in cardiovascular benefit. And all the studies which have shown renal benefit are actually offshoots of studies which were done for cardiovascular benefit. So the numbers may not be adequate, but there are a lot of studies which have already been started. We'll get more evidence, but definitely they do help. And like ma'am has already pointed out, there are a large pleiotropic effects. Please go on.
The pleiotropic effects, it increases the hematocrit. It decreases the oxidative stress. It causes weight loss. It decreases the cardiac preload and the wall tension. It decreases the inflammation. It also decreases the intrarenal renin and angiotensin system activation.
So and tissue RAS activation is decreased.
Tissue RAS. But what are the problems with SGLT2 inhibitors? Which are the patients we should be very careful when we start them?
When we start them, we should take a history whether we should always assess the volume status of the patient. We should not give it to a volume depleted patient.
Okay.
We should, in cases of if the patient has got any sick days, we have to advise the patient how to manage the sick days. If the patient has got history of recurrent UTI, we cannot use the SGLT2Is, and we have to warn the patient of some rare side effects like Fournier's gangrene. And rare patient.
There are
fungal infections.
Have you heard of euglycemic
ketoacidosis?
Yes.
Can we also come to the present case? What happened?
Yes. What is happening to the patient now?
So the patient is still admitted with us, and at present the urine output has improved, and patient is not requiring any dialysis. We are we are basically observing the patient.
Have you given him steroids?
No, sir. We have not given steroids.
If you have made a diagnosis of acute interstitial nephritis and you have a short course of illness, within 7 days urine output has gone down, he has required dialysis. Biopsy does not show significant chronicity other than the fact that 5 out of your 21 glomeruli are sclerosed. I would say you're looking at a possibly actively redeemable acute interstitial nephritis.
Yes.
Professor Nair, probably we haven't added steroid because the creatinine started dropping down itself.
Okay, ma'am.
So that is why we didn't put him on
because
steroids.
The urine output is improved. The patient has definitely had some acute injury. There is no doubt about this.
About it, yes.
And in the absence of everything else, your biopsy points towards an AIN. It could have been a urinary tract infection which has come and gone. It could have been some drug he has taken, some allergy he's had to something. Maybe you could retrieve some renal function by adding steroids here. Further ahead, are there any more slides?
No, sir.
Okay. So the next one is glycemic control. We have decided that SGLT2 inhibitors, DPP4, and our GLP-1 agonists are the drugs of choice today. What kind of insulins would you prefer to use in these patients? Or rather, let me put it simpler. Why do CKD? What percentage of diabetics are diagnosed to be diabetic when they present with CKD? A very rough figure. What do textbooks mention?
25%.
Pardon?
So I'm not sure.
What percent? So, what percentage? Almost 5 to 10% of diabetics may be diagnosed to be diabetic for the first time when they present to you with CKD, which means they already have a decline in GFR. So yes, Dr. Chandni has already mentioned twice that long-acting insulin should be avoided. So why do CKD patients tend to have hypoglycemia, earlier hypoglycemia?
The half-life of insulin increases. Sir, your voice is getting, cannot hear you properly.
Yeah, sorry, the internet connection. Can you hear me now?
Yes, sir.
My question was, why is hypoglycemia common in diabetics? 4 or 5
So there is
hypoglycemic patients with DFR.
Sir, apart from the increased half-life of insulin, there is also a defect in the renal neoglucogenesis. The patients, there is impaired renal neoglucogenesis, and the half-life of insulin
What percentage of the, yes,
70 grams of around 70 grams
of the body.
Around 70
Percentage wise, there is gluconeogenesis in the fasting,
in the liver
in
and kidney, mainly the liver and the kidney.
Fasting state and in the fed state.
Sir, I am not sure. In the fasting and the fed, I am not sure.
So in the fasting state, up to 50% of gluconeogenesis occurs. Fasting to 50% of gluconeogenesis occurs in the kidney, and in the fed state. In the fasting state, up to 70% of gluconeogenesis occurs in the kidney. Third, these people, because of CKD, their appetite is poor. They don't eat very much. Their glycogen stores may be low. Fourth, diabetic dysautonomia prevents them from mounting an adequate counter-regulatory response. So these are all facts you must remember that these are theory answers, but you must remember them and they do contribute. In this patient, of course, he has no dysautonomia. He has no evidence of neuropathy, and he's not had hypoglycemia as yet. But this is why hypoglycemia is common, or rather it is more likely to occur as the renal dysfunction worsens.
Rajarshi, other than ACE inhibitor and antihypoglycemics and statins, this multi-prong approach to control of diabetic nephropathy, can you mention any trial that has given you evidence that this multi-prong approach to diabetic nephropathy has really going to give the patient benefit in long run?
Madam, mineralocorticoid receptor antagonist, the finerenone, the Fidelio trial.
No,
Fidelio
I am not talking. I am talking about a multi-pronged approach to diabetic treatment of diabetic nephropathy. Is there any trial which has looked into it for a long time with multiple factors addressed, and quite a famous trial? That is a Steno-2 trial.
Steno-2 trial.
Yeah, that had come with a very long follow-up of nearly 13 years, and multi-pronged approach is used, that is perfect control of blood pressure, perfect control of glycemic profile, control of statins, lifestyle management, everything added had really improved in the outcome of the GFR protection. So yes, you were talking of finerenone. Is finerenone coming up as a big help to treat the diabetic patients? What are the evidences?
The Fidelio DKD trial, It can be given to a certain subset of patients.
Let us talk a bit about finerenone. What is finerenone?
It is a mineralocorticoid receptor antagonist. It is
what is the difference between the other mineralocorticoid antagonists that you people used and finerenone? Other mineralocorticoid antagonists were also tried in some trials now. So
finerenone has got
what was the problem with other mineralocorticoid antagonists, and what is the difference?
The finerenone, the problem with mineralocorticoid antagonists is the incidence of hyperkalemia and also AKI. The finerenone, it causes comparatively less hyperkalemia compared to spironolactone and eplerenone, and it also causes a decrease in proteinuria and has also got cardiovascular benefit.
Yes, and it is said that the finerenone is non-steroidal and it has a balanced distribution between the heart and kidney.
And the heart.
Kidney has more other mineralocorticoid receptors target kidney more, and finerenone is a bulky molecule that the stoichiometric attachment of other mineralocorticoid receptors are like that they can cause more receptor antagonist effects in the kidneys, which is not there with finerenone. What did the trial evidence tell you?
The Fidelio DKD trial said that the finerenone has got cardiovascular and proteinuric benefit, but it has also more incidence of hyperkalemia compared to placebo.
Compared to placebo, what was the incidence of hyperkalemia? Can you remember?
15%.
No.
Madam, there was actually 3 trials: the Fidelio, Figaro, and the Fidelity.
Yeah.
The Fidelity analysis compiled both the Figaro as well as the Fidelio. There it was around 5 to 6%.
Yeah, even so far I remember it's even lower, 2.3%. But let's come to the practical situation. When RCT is done, sometimes we do not get the real world picture with it. It might not be as low as 2.3 that has been mentioned there. We should, whenever we will be using these drugs, we must remember that we are using it out of the RCT scenario where the follow-up is very, very stringent, and the doctor is very much in touch with the patient, and the way patients are taken care of is little different from what we do, what is possible for us to do in real world. So it's better to accept that it's not nil hyperkalemia, and even when the finerenone may give us some degree of benefit, cardiovascular and antiproteinuric, we will still have to remain cautious about hyperkalemia. Yeah, any question, Professor Nair?
Hey, ma'am, I think we have already exceeded our time.
Well,
we'll have to take
how reliable, I think the 2 examiners are there. How reliable will be 24-hour estimation, or what you said, the UPCR of 11 grams in a person who is having 300 ml of urine?
Sir, at that point of time, patient had slightly increased, around 700 ml at that point of time when it was measured. Should have.
So I think that,
but still it is a lot.
But even then, very heavy. It's very heavy protein.
Yeah. So I think there are a lot of things which the case has taught us. One, it is clearly showing that a massive good amount of proteinuria is possible, occurs in many diabetics. Many diabetics, we tend to biopsy expecting some glomerular disease in addition, but most of the time we fail. I remember at least 15, 18 patients I would have biopsied because of this proteinuria, and most of the time you find there is nothing addition. I don't say most of the time.
Agree, sir, 100%.
50-60% of the time you find it is only diabetes which is responsible. So it can have a lot of proteinuria. Second, the biopsy-wise also, as you said, possibly acute kidney injury was a dominant thing here. What caused acute kidney injury, you have not clearly brought out what it was. that there is a history of NSAIDs, which you said 3 months back, and the manifestations had come only 1 week back. When you say for 1 week, he was having shortness of breath, difficulty in walking around, features of fluid accumulation were there. And you brought out 300 ml of urine with 2 liter intake. So that means he was fluid overloaded. That is why he was breathless at that point of time. And the biopsy is showing class 3 lesions, that there is chemistry Wilson lesions. There is, of course, we have not seen more than 50%, but a lot of glomerulosclerosis also, 5 out of 23 something.
Yes, 5 out of 21, sir.
Not huge. And IFTA is hardly any 5%.
And the viable glomeruli are all normal, sir.
Yeah, they are all normal. So I don't know how much is the correlation between biopsy and a clinical picture otherwise. Secondly, I think a very important thing has been brought out, that you must remember it is the drugs and infections which are the dominant cause of deterioration of renal functions in such patients, and that has to be kept in mind. And finally, possibly we don't know the examiners till what stage ACE ARBs we keep giving. Many centers keep giving even up to the stage of dialysis, and many centers possibly are not able to give full benefit of ACE ARB because of the hyperkalemia, possibly with the potassium lowering drugs which are in the offering, and possibly in a couple of months which are there in India. Maybe we shall be able to give the benefit of ACE and ARBs for longer period of time. Professor Kher, sir, are you there, sir? Professor Kher?
Sir, there was a trial looking at that if we continue on giving ACE ARB even in stage 5, whether we are really going to benefit the patient.
Yes.
So that trial concluded that there was little more initiation of dialysis due to hyperkalemia in the ACE treated ACE or ARB treated arm, but the cardiac benefit was profound, and the all-cause mortality and CV mortality were less in the ACE ARB treated patient.
That's what I said.
Higher dialysis.
Once we have this potassium lowering drugs, which are going to come in near trisilicate and all that, possibly we may be using them to a longer extent. I think Professor Kher, are you around, sir? I think if not, I think I thank both the examiners, Professor Arpita and Professor Ranjith Nair, for covering the topic very well. Again, a masterly way. And we have brought out what are the relevant points. They have discussed the pathology, the clinical spectrum, how to manage, and more importantly, how to analyze the case. I think Rajarshi discussed the case pretty well, and he was well prepared with all the new potassium, all the trials, what are existing in diabetic. It's a huge topic. It's a huge topic, and maybe it is not possible to cover every aspect of that. Possibly, I would have gone a little beyond also how they tolerate dialysis, possibly what form of dialysis modality is beneficial, what happens to transplant, ideal way. I think it's a lot of scope for going ahead for that also.
Second class will be needed, sir.
But I think with the limited time,
you need a full class for CKD and for
I think
transplant and dialysis diabetics.
Compliment both the examiners. I think a lot of students, we had 150 plus students. I think there were 65 on YouTube and 95 plus on Zoom who have benefited from them. Once again, I thank you both for your wonderful discussion of the case, masterly discussion, and Rajarshi also for presenting the case. Thank you very much.
Thank you, sir, for giving me the opportunity to come into this platform.
Thank you for the opportunity, sir.
Yeah. And it's a very nice experience, Ranjith, to see you again, even on Wave. We used to see each other for a short time when he was in Kolkata.
Oh, yeah.
Regularly in Calcutta, yes.
And Mr. Raja.
Thank you so much, sir.
Thank you very much. Mr. Raja, if you are around, Mr. Deepak. Yeah, thank you very much.
So thank you, sir.
Yeah, for the final word.
It's been an honor to have your today's program. I would like to express my heartfelt thanks to Dr. Brigadier Ranjith Nair, as well as Dr. Arpita Roy. Despite all your busy schedule, you could really spare your time. And thank you once again to Dr. Rajarshi Datta also. I think, as Sir has mentioned, it was a good kind of a debate, good knowledge program. We once again thank all the students who have spared their time and participated for today's event. And we look forward for your participation in the next edition. Thank you, one and all. Good evening and thank you, sir.
And
thank you all. Good night.
After 2 weeks, we are having a discussion on CKD dialysis management. I think the group from Bombay will take over. Thank you very much.
Thank you,
Bye-bye.
sir.
Bye-bye.
Good night. Bye-bye.